Professor of Nursing at the University of Liverpool, and she's also the Director of Nursing at University Liverpool Hospital. So you've come from Manchester, is that right, Michelle, over to Liverpool? Yeah. And I think you literally started last week, was it?
Last week before? Yes. Yeah.
Yes. Yeah, so we've obviously jumped straight on you, as we do. So yeah, a warm welcome from us over at Walton, and we also have other wider members from other universities and services that will come to this meeting as well. But we're all part of the wider pain world across Merseyside. So Professor Briggs has got this wonderful mix of clinical and academic career. So you've got a background working in pain services, I believe, Michelle, as well as having a portfolio of pain research. And then you've also been developing guidelines for people with pain as well. And you're also a trustee of the Pain Relief Foundation. So this isn't half of what Michelle does. So I didn't want to take up the whole presentation with all the wonderful things that you do. So do have a look at the blog attached to this REM invite to find out a little bit more about Michelle's background. So you're here to present to us, Michelle, about your new role and your aspirations, and to open up the opportunities for our pain network, really. So thank you for being here. So whenever you're ready, Michelle, if you want to kick off.
Well, thank you very much for the invitation. I do have some slides. I'm hoping to speak for about 30 minutes, but shut me up at the point that you need to shut me up. That's absolutely fine. I'm going to talk a little bit about clinical academic role and then also my current pain research. So I hope that's what you're expecting. But if there's anything extra that you need me, feel free to chip in on the chat. Having said that, once I share my screen, be aware I won't see the chat and I won't see you putting your hand up. So shout out if you want to stop me and have a conversation about anything that I'm presenting. Does that sound okay? So I'm going to share my screen. And just go into slide share. Can you see that?
Yep, that all looks good.
And so that's the title I was given, my role, my aspirations and my opportunities for pain research in 30 minutes. So I'm going to do my best to just give a little bit of an overview. I felt the first thing that I would start with is just to how did I get here and where have I come from? So this is a quick whistle-stop tour. First degrees in chemistry, that was at the University of Nottingham. And then I did one of the accelerated research nursing registrant. So that's a 2.5 year accelerated course to be a registered nurse following my chemistry degree. Worked in Nottingham in trauma orthopaedics and then moved to London to be part of the helicopter emergency medical service. And from there went to St James's at around about 91. And that timing it links, if anybody in pain will know that timing links with around about the publication of the pain after surgery report and the setting up of acute pain services. And so I was part of the multidisciplinary team setting up acute pain services at St James's. I was there for 5 or 6 years and then moved into community trust, setting up some community-based pain services in Leeds Community Healthcare. That's where I did my PhD part-time. My PhD was in understanding pain in leg ulceration and whether pain was a predictive factor of leg ulcer healing. The bottom line of that one was, it was difficult to say. It was a longitudinal follow-up study, but neuropathic pain did have some sort of predictive element around leg ulcer healing. So that's my PhD. From my PhD, which I did it in Leeds, I was then, I'm sorry, that keeps popping up, so I do apologise for that. From my PhD, I was then faced with the decision of, do I stay in clinical practice and stay within pain services, or do I move into academia? At that point, there wasn't really any choice to do one or the other, to do both at the same time. So I applied in 2006 and got an NIHR postdoctoral award, and was a senior research fellow at the University of Leeds. And from the University of Leeds, I moved into, and one of the reasons for going to the Manchester job was it was an opportunity to move back into a 50-50 post where I have a clinical and a an academic role. So for the last 7 years, I've been in Manchester. I've been the director of the Clinical Academic Centre for Nurses, Midwives and AHPs in Manchester. And then I was very excited to see the job in Liverpool advertised and have the opportunity to work with all of you, because I'm aware of the fabulous work that you're doing in Liverpool around pain research. So and as you say, Katie, I've been here a couple of weeks, so I thought that's sometimes useful just to give you that. And that journey's taken me about a little over 30 years. So in terms of what my aspirations are to certainly, and this is so 2 sides of the job. The first part of the presentation is going to be about my Director of Nursing role. That's the meeting I've just been in, is the Senior Business Nurse meeting in Luft, and saying, what does research activity look like for the nursing, midwifery and AHP workforce? Because of course we often talk about, oh, I'd like to do a bit of research, whereas actually my aspiration is that we should move towards anybody who is on a register as a health professional. That is not negotiable. What we need to be having, we need to shift the dial and shift the conversation to saying, what is my role in research and how do I find it out? And this is what is often referred to as my onion model. This is the way I explain it, is if you think of this as the total NHS workforce, that the total NHS workforce should have research awareness and should be research enabling or supporting research. And what that means fundamentally is keeping up to date, knowing where the guidelines are, knowing how to contribute to guidelines, knowing where to find the research, and knowing what studies patients are eligible for. That should be entry level for anybody who has a registration. Then the vast majority of our workforce should be able to implement research or de-implement. So they should be able to design projects that lead to implementation. There's a fabulous paper that shows that from research findings being published to them being integrated into practice is about 17 years. Clearly, we need to get better at that. Then there's a whole group of people in Luft, it's about 150, who are research delivery staff. So their role is very clear, very defined. It's making sure that people are safely recruited into studies, they have good clinical practice, patients stay safe when they're in studies, and that the research that we design is delivered well. And then at the bottom of this onion is a small percentage, and if my memory serves me correctly, with our medical colleagues, it's about 4 or 5%, but it's flatlining, I think. Please correct me if I'm wrong. In nursing, at the last count, it sits somewhere at 0.01% of the workforce. So it's tiny, and we need to, so my aspiration is we need to be able to, along the clinical academic pathway, encourage, enable and fund more people to be taking up internships, pre-doctoral, doctoral and postdoctoral awards. So I'm hoping that this will move on. Doesn't seem to want to. There. I'm just going to highlight one of the papers that I wrote with a group of colleagues. So my role, I'm not the only person who does this role, which is a clinical professorial role within nursing. There are a number of us, but there aren't many. And one of the papers that we did, which I would signpost you to, is we did a framework analysis. That's a type of qualitative analysis to say, in our jobs, what are the things that make a big difference, and where the success criteria in enabling people to be research active? This is the model we came up with. The thing that I want to point out is that the environmental facilitators are clinical and research area alignment, so that your clinical practice aligns with the research work that you're doing is incredibly important. And at the bottom here, clinical and academic institute appetite for joint working. So that recognition of moving beyond, oh, wouldn't it be a good thing if we had, to these are business critical posts. So that's, again, and why do I say that? Why do we need to move to having clinical academics as business critical posts? There's some references. I'm happy to make these slides available for anyone, but the pathway is that if we're serious about evidence-based practice, then putting these posts into place is evidence-based. It has a positive effect on trust, performance and staff performance, and that's measurable at the patient level, even if that patient isn't in that research activity. So the more research active an organisation is, the better patients do. Also, there's some qualitative evidence. It's not as strong as the measurable patient level data, but there is some qualitative evidence that there is better staff recruitment and retention, and certainly people are more likely to recommend the trust to work at. There is a correlation taken from the CQC data, that's from 129 trusts, to show that there are increased research activity and reduce patient deaths. Again, it's a correlation, but equally that also carries over irrespective of whether or not those patients are in the trials or not. It's a carryover into the whole trust. So better overall experience, and we're putting evidence into practice. If anybody, and this slide is just so that if anybody wants some extra data about why I'm claiming those things, on and why you should invest, there's just a little bit of extra notes there around why clinical academic posts are important. The final thing about why clinical academic posts are important is this is the Council of Deans metrics around improving career pathways for clinical academic careers in healthcare. It's a key priority nationally. This is the data that I was recording earlier. This is the national census of the 94%, sorry, I should round down, of returned individuals, which is of thousands in this survey. Only 3% were clinical academic nurses or midwives, and only 2.5% were clinical academic allied health professionals. There's a different range depending on which profession you're in, but certainly when you focus on something like children's nursing or learning disabilities nursing, it's a tiny percentage. And these are some of the key headlines from our latest Council of Deans survey. And again, I've put a link to a blog there, but there is a step change. There is a recognition that organisations have research strategies. They're recognising the importance of this. So and recognising the importance of having links with universities. Our challenge is to make these posts attractive and to make these posts workable. And this is the, I'll point you towards the national strategies that are driving this. The Future-Proofing UK Health Research. If you've not read the Academy of Medical Sciences report, there's a QR code there if you want to download it to read the full report. But the point that I would be saying is they have a clear drive to say that we need to release the power and potential of the NHS to deliver research and put more active focused attention, particularly, and this is the quote that I would say, is that place people at the heart of health research and allow a cross-organisational movement. That's what that graph says. The other thing to say from a nursing midwife and AHP point of view is recognising from the National Institute of Health and Care Research that in terms of strengthening research careers, there is a real drive to make sure that the funding goes to underserved regions and communities. And actually, that's also means that they want to fund research delivery staff, but the point that I would be pointing out here is underrepresented disciplines and specialisms, and a real recognition now and more money. NIHR announced 30 million for the next 5 years per year for underrepresented disciplines and specialisms. So we have a real opportunity to increase the number of specialist professionals who are in research. So that's the, if I can, not very good at there. So that's the clinical academic job. That's my director role. The title of my post within the trust is Director of Nursing for Research and Academic Development. And those are my aspirations around increasing the clinical academic career opportunities. From a pain point of view, how am I doing for time, Katie? Am I doing okay?
Yeah, you're fine. We're only 20 minutes in, so that's lovely. Yeah, carry on.
Yeah, so the other half of my job is as a pain researcher, and this is the nursing quote about pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does, which I don't know about anybody else, but this definition gives me heart sink. Because in reality, talking about pain is really difficult, and generally patients, it sort of says we should believe our patients, which seems to be a fundamental level. But one of the real challenges is recognizing, this is Pat Wall, a quote from Pat Wall in 1979, is that pain is better classified as an awareness of a need state. And I'm acutely aware there are more people on this call who could challenge this, so please do. If there's check and challenge in this presentation, please let me know. But I've always found that this was a really useful quote around what pain is, in terms of it serves more to promote healing than to avoid injury. It has more in common with the hunger and thirst than seeing or hearing. And certainly from my whole research area is around, from a nursing point of view, how do we get better at communicating, recognizing and helping people talk about their pain and get the pain management that they require. The other area, that one of the theories that underpins my work, is recognizing the physical social pain overlap. So this is a recognition that actually there's no such thing as social pain over here and physical pain over here, and that actually very often they share the same neurological underpinnings. And again, I've put a YouTube quote, a YouTube link into that for another time, where you might want to look at the difference between social pain and physical pain. What I mean by social pain is those times where we're stigmatized, excluded, when a relationship breakup, lack of connections, all of those things that we now know trigger in the brain the same mechanisms and the same processes that having a physical injury would do. So there's a much bigger overlap. And here's some of the papers that talk about that, around us recognizing that social interventions and being able to be socially connected have pain relieving activities. So from a nursing point of view, this is exactly, from a nursing intervention, what we do and how we can do. We also have an opportunity and a risk of creating painful situations when we stigmatize patients, or we marginalize patients, or we tell patients that they need to be talking about their pain in a particular way. So I often talk about Maslow's hierarchy of needs at this point, and we talk about physiological needs, and I think Maslow got it wrong. Because actually, if we're all, and I think we probably are all human on the call, I don't think there are any aliens here, but at this point, we're all here and we're all still breathing because somebody loved us enough to feed us and give us water and shelter and clothing. So actually, for me, self-esteem and love and belonging should be at the bottom of this, because we would not survive unless we had somebody somewhere connected with us. And that's the theoretical underpinning of where my research work really is driven is understanding connections, how we make connections, how we socially support people, but also how we hear the voice of those people whose pain often goes ignored, or is often ignored or overlooked. So you'll see a theme, and so what I'm going to do is just give you a very quick whistle-stop tour of the last 10 years of research in terms of publications of what we've done and where we've gone. So this was a systematic review that we did in 2011, and this links to what I was saying, is pain is what the patient says it is. So in 1996, there were 42 stories of nurses who care for patients with pressure ulcer and said pain is the worst thing about having a pressure ulcer. Then again in 99, 2000, 2002, 2003, 2007, there were 2 qualitative papers. 2010, another 47 patients say that pain was constant and the worst thing, until the 2011 systematic review, which showed that actually all of patients saying what the patient pain was had been consistently ignored for people with pressure ulcers, and everybody focused on healing the pressure ulcers and not in any way looking at the place of pain. It's led to a programme grant exploring the role of pain as an early predictor of pressure ulcers, looking at, if you looked at any pressure ulcer risk assessment scale, pain didn't feature, looking at the prevalence of pain in pressure areas and pressure ulcers, and looking at pressure ulcer related pain. Not surprisingly, what it showed, because every one of us sitting down, the indication to change position will be because you are getting sore or uncomfortable. And if you can't move, pain is a feature of pressure ulceration. So, so one area of my work is chronic wounds and how pain in wounds is managed. Another area is qualitative systematic reviewing. So a metaethnography is a way of doing, you might be familiar with Cochrane systematic reviews. One of the areas of expertise I have is pulling together in a similar way all of the qualitative data to make sense. This is a result of a metaethnography. It's the qualitative equivalent of a forest plot. But what it shows here in one way, this is again about 10 years ago, is understanding how people move forward with pain. Here what you can see is that me in pain in the middle, and this was the result of all of the qualitative studies that had been done over 20 or 30 years around what patients were telling us what it felt like to have chronic pain. And as you see here, the struggle to affirm self, the old me is the real me, this new me is not me, I've got an alienated body, I'm isolated, and that what you see all the way through, and I'd really probably, this is what I talk to a lot of people who are not in the pain world, is what you see continually is strategies to gain legitimacy. So that's being valued, and a healthcare system that doesn't allow that to happen. And now when you see flipping pain, the Laura Mosley work, a lot of the work there is all about helping people generate an acceptable explanation for their pain. And what that model showed was that the things that make a difference, that help people, are refining a positive sense of self, learning ways to communicate. Hopefully you can see the thread that is about learning ways to communicate, knowing you're not the only one, gaining a sense of social participation, and recognizing the limitations of the medical model and being empowered to experiment, and having clinicians that will be able and willing to do that. So you'll be pleased to know I'm coming into the homework, because I want to leave a lot of time for questions. Where am I now? So that's where I've come from, but that's previous research. There's a link on here in terms of my publication, so feel free to click that. Where we're up to at the moment, there are a couple of areas that are around post-surgical pain, the impact of post-operative packing and perineal abscesses. That was published last year. What that showed was that packing perianal abscess cavities causes an extreme amount of pain and does not do anything in terms of healing. So we should stop packing. It shouldn't be something that you should be doing. Again, I'm happy to talk about that. That's the bottom line on that trial. That was a multi-centre trial with surgeons across the UK. Patient self-reported and real-time education of breast cancer surgery. So this is an example of when a woman or indeed a man gets diagnosed with breast cancer and they're going for breast surgery, they will be told within 2 weeks, yes, it's cancer and you're going to go for surgery, and that surgery will be day case, which means that at the end of the surgery, they will be back at home, and the person who will be managing their pain relief is their GP. which has a significant problem when we know that if pain isn't managed well in the immediate post-operative period, then you're much more likely to get chronic pain. As a result, it is a predictor of having persistent post-surgical pain. And for some reason, breast cancer is one of the highest prevalences of that. So what we've developed, and I'm keeping my fingers crossed in that it's at stage 2 RFPB at the moment. With one of my postdocs, we've developed a web-based intervention, which is real-time self-reporting of pain scores and wound and other post-surgical complications. It's called ePainQ. What happens is a patient will be given that pre-surgery to be able a username and to log on, and then they'll be able to log their pain scores. But there's an algorithm behind the pain scores and the reporting that targets the education depending on what their pain scores. They're also able to graphically produce their pain scores, so when they come back to clinic 3 weeks later, they'll have a full graphical display of what their post-operative pain journey has been. But also, as well as that, it has alerts to the breast cancer nurse specialists. So if somebody, and you can set those alerts. So if somebody is scoring persistently 9 out of 10 for the first 24 hours, it will alert to the breast cancer nurses that this is somebody who needs some extra support. So we've developed that. We've done the feasibility study. That was and we're currently out to second stage to see if we can lift and shift that, because it's in the Leeds electronic patient record at the moment, but we need to be able to lift it and put it into 2 other sites and open it out into the NHS electronic record, which is no mean feat. There was a paper at Budapest. I'm happy to share that poster because I'm sure you won't be able to see that, around the work we're doing with breast cancer. From a physio point of view, these are 2 recent publications, 22 and 23, around rethinking pain education and looking to flip the classroom into helping people have practically engaging content that actually reflects people's experience of pain. So certainly within Leeds and within Manchester, we were aware that from a physiotherapy point of view, a lot of the education was nociceptive based and drug based, which is good. And I'm not suggesting that that shouldn't happen, but also there wasn't much education around helping people have good conversations about pain and being able to help people face the challenges in clinical practice of some people do extremely well and their pain gets better, and that's great. But other people, no matter what you do, their pain is not going away. And how do you help people clinically in that sense? So if anybody wants to know more about that, that's the model that we've come up with. And if you, hopefully you can see some of the things that are in there around educational deliverables that are linked to the meta-ethnography that we did 10 years ago. So if you want to know more about that. And then the final thing that we're just analysing the data for now is that we know within big data sets that pain and frailty go, that there's a strong correlation between pain and frailty. The more frail you are, the more pain you have, the more frail you are. And that comes from the ELSA databases, the English Longitudinal Study of Aging, is that there is a direct and positive correlation. However, what we don't know is what comes first. Do people get frail, stop moving, their joints become sore, have repeated falls and therefore have more pain? Or is it a case of actually, and as you can see from a timeline here, this is a narrative, it's another type of qualitative method, but it's a narrative study. So we've been following people's life courses around what's happened in their life and at what point did pain become a significant feature. So this isn't obviously, if you asked at what point did you first feel pain, everybody's going to be saying in their childhood, but actually at what point would they say that pain was a chronic condition? Here you can see one of the examples of the timelines that we chart. This person had an accident at work, a back injury, and then work refused to retrain and terminated employment, severe pain in lockdown, and then interestingly, at this point, this person received some compensation and travelled to Vietnam, got some really good pain management at this point, but then had to come back to the UK at 67. He was fearful of falling, his activity reduced, and he attributes that primarily for the pain management support that he was getting was no longer there, and within 2 or 3 years deteriorated and became frail. What we're doing is we're plotting all of the life histories of a number of people who have pain and frailty to see what came first and see if this is an isolated story or whether there's a meta narrative. So that's is there a joining up story for all of the patients? Of the 12 in-depth stories that we've got, 11 out of 12 the pain came first, and one of the 12, that person got really good pain management and has been able to not be as frail as the others. And we're just analysing that data. So I'm not very clear at presenting that one at the moment because we're in the midst of analysing. This is Lisa's PhD, and she's pulling that together. We're also have been massively surprised about the number of adverse child events. We don't know whether that's significant or not, but I'm going to leave it there because I'm hoping I haven't made you feel like that, because I'm acutely aware that I have rattled through, because I want to be able to open that out to questions. So I hope that's been helpful, and it gives you a very broad overview of the 2 jobs that I'm hoping to be doing whilst I'm in Liverpool. I'm going to stop sharing my screen at that point.
Thank you very much, Michelle. It's really interesting to hear about your background and what you've done and what you're currently doing. And it sounds like we're going to be good friends.
Oh, good. Good.
So, yeah, I mean, I've got a couple of questions in mind, but I will obviously open the floor to the team. So for those of you hearing that, has anyone got any questions for Michelle? Sometimes people are polite and they don't quite jump in straight away.
Any challenge, question, comment, I'm open to all of it.
Yes, I know. Thank you for offering us to challenge you in some way. So my questions aren't too challenging. I'll kick off with one of mine anyway. I guess my first one is just in your experience, and similar to yourself, I've got a combined clinical and research role. It's more clinical, but I do have 1 day a week research. And I just wondered if you had any advice for those of us that are under pressure to see more patients and do more clinical work. How do you approach managers in the trust to protect that time for research when your staff member is embedded in a clinical role?
That's a really good question. I'm going to go back to my chemistry roots here and say clinical practice is a bit like a gas in that it expands to fill the space available.
Yeah.
And so if you give it 100% of your attention and space, then it will fill it. And so you just have to be, and I say just because it's not easy, but really boundaried and okay at just being unpopular.
Mm-hmm.
I mean, that's just my advice, is to recognize that you have dedicated spaces to do both things. And the problem with research is unless you're actually funded doing a trial and the patients are being recruited and you've got a recruitment clinic, which does really force, so that really helps, because if you've actually got targeted work, but the enabling work required to do that, get the funding in, do the publications, all of that is just quietly sits there and nags you, but doesn't demand any attention. And the clinical work requires you to be reactive and demand attention. So you have to, tiny little things that I do. I colour code my diary. I make sure that on a Friday I do a checkup and say, there's a different colour for my research activity and my clinical activity, and I absolutely make sure that on that particular week it looks like 50-50 roughly. And if it doesn't, if one's been more of a hungry beast than the other, then I make sure I recoup that within the month. So colour coding helps me. Is that the sort of thing, Katie, you?
Yeah. I mean, definitely for us all, for our personal resources, it does require, that's a skill in itself, I think, of being able to work differently and protect that time differently when you say you need to be so reactive to our clinical stuff. And you were saying before as well about how research really does help bring us up to speed with the current evidence base. It improves our practice. And I think that's a really good selling point for the wider trust and managers when they might say to us, why can't you see more patients instead of doing this research as well as ourselves?
I usually push back in my director role, which I've just done, is that I shouldn't have to sell research. I don't sell infection control. I don't sell safeguarding. I don't sell falls prevention. There is enough evidence to suggest that research is a safety critical activity that I shouldn't have to sell.
Yeah,
is a phrase that I use a lot. And that if you say that your staff don't have time for doing this, what you're saying as a director, that it's not a priority, because we all have exactly the same amount of time, but we choose our priorities. So it's a really useful conversation to say, oh, actually, I'm getting from that research isn't a priority at the moment. When will it be a priority?
I might steal that phrase. Thank you. That's a good one to have in your armour.
Is because actually, none of us create any more time than anybody else, so we just get to choose. So if we're making choices that don't have research in it, especially if they've already made a choice to say that your job plan has academic sessions in it, they've already made that choice and said it was a priority. Therefore, they're not enabling you to do your job plan. So that's another way to talk about it, is how am I going to be enabled to deliver the job that you'd like me to deliver, because that's what you employed me to do.
Absolutely. No, that's really helpful. Thank you. So yeah, that was a bit of a selfish question from me. I've got another question looming, but does anyone else have one at this point? No hands up. Sometimes on a Friday. Oh, go on, John. You've got one, have you?
It's not a question so much, more a comment. But I think one of the things that makes research tricky, I think, is first of all, you're confident in your ability to, know all the stuff you need to know, and who do you ask and how do you get support for those things. But also, I think there's a huge emphasis throughout the NHS on medical and nursing staff, and lots of things you hear about are very focused on medics and nursing. And I think, we're a department that's really heavy on AHPs versus medics and nursing. And I think sometimes that puts you off as well. It's like, is there space for me here? And so I just wondered if you had any ideas kind of more globally about that, Michelle.
I mean, I'm hoping in the presentation I referred to NMAPs, which was AHPs as well. I think that the challenge, I think, John, it's absolutely one of the things that is incumbent on us all is to be more visible. And one of our challenges, and it's an AHP challenge, I think, more than a nursing challenge. One of the challenges for the nursing challenge is there's just so many of us. There's like thousands. So when you're an academically active nurse, that there's a dilution effect, because there's just so being seen is difficult. From an AHP point of view, you've got that dilution effect, but there's fewer of you, but you've got 14 different registered professions. So finding the right profession to connect with, and forgive me if you don't see this, but I see this, is very often people talk about AHPs as if they're one thing. And they don't, and it doesn't include psychologists, and doesn't include pharmacists and healthcare scientists and microbiologists. And actually, I prefer the term health register. If you notice in the presentation, I talked about registrants and health professionals, because actually that's what joins us up, because the skills are roughly the same, irrespective of whatever professional group you are. And the challenges are exactly the same. I don't know if Andreas would agree, but from a medical point of view, I think the other professions seem to think like medics have got it really good and that they don't have the same challenges. And what I see working with my medical colleagues over the period of time that I've been working is we're all juggling the same things. You know, it's actually, there's way more that connects us all, and that actually joining it all up into health professions makes a difference. Has that answered your question, John? I'm not sure it has.
I think so. I mean, I think I'd just like to see more representation for AHPs and more, people you can say, yes, I know what you're talking about. You're talking my language. And obviously that's going to come with more people being involved, isn't it? But I think the other part of it was about our confidence to do that, because I never have seen myself as a researcher or having a specific interest in research. And I think, again, I am trying to challenge that, and I am trying to get more involved in that. But I think there's a lot of people who feel that way.
Yeah, I think there's I tend to focus it more on saying, rather than, oh, I'm getting more involved with research, which can seem really overwhelming and quite big, and it's like a massive thing, is actually in this job, what's my role in research? Is it, and I tend to say, think big, absolutely think big, to say, I want some element of my career to have research in it, but start small and do something this week. So saying, right, well, if that's my think big, then what this week can I do within the job that I'm in? So is there a trial open at the moment that I can recruit people into? Is there, which I suspect is exactly what you're doing. And it's like building those small steps into, before you know it, you look back and you're talking about a career like I've just spoken about.
Yeah, that's helpful. Thank you.
I think sometimes as well, it's having that sort of supervision and mentorship as well, which is what we often feel that we need as healthcare professionals, isn't it?
Yeah. I think that's where medics have got it way better than, they have got their systems and mentorship so much better than ours, I would say. And that often I look to, things like the academic clinical fellow, the clinical lecturer, that mechanism is much better. And also as medical students, I think we're getting better. Hopefully we'll get some funding. We're just part of the Insight bid at the moment, which is trying to get more funded master's programs. I'm very happy to come back and talk about that at another time if we get the money. But I think you're right. Linking people up with mentorship is key.
Natalie, you got a question? Got your hand up?
Yeah, thanks. I'm hoping I can form it into a question, but I'm just going to do my usual reflection, maybe as typically as a psychologist. But it kind of links. John sort of sparked a connected thought with me with representation, and it linked to what you were saying, Michelle, about you don't have to justify infection control. So therefore, why do I need to justify research, and particularly if it's in my job plan? I think for AHPs or the old school others, and anyone who's not medics and nurses, where we struggle is it's not even in our job plans. So we're scrabbling even for time to do that, even if the inclination is there. And we're really lucky in our support in our department that we do have that mentorship for research, and particularly the really good connections with the medics for that as well. But we're still having to really heavily lean on medics and nurses who are in the committees, because even in a trust that compared to other trusts does celebrate its others, we do now have an AHP lead, but that person doesn't sit in any of the same meetings as the nurse director or deputy director of nursing or the medic. So it's even though it's oh great, we've got a lead, it's but the lead is at a financially much lower level, so doesn't even sit on any of the, and then they report to the deputy director of nursing, who then picks and chooses what's discussed in what meeting. So we have more representation than other trusts, but we don't have representation at the same level as nurses and doctors. So that's why we still do heavily rely on those professionals that we're working with who do have the ears of those directors and those executives to do a little bit of fighting for our cause, unfortunately. So I'm cycling it back round to, as in, rather than a question, but if this new link and new working relationship sort of can be mutually beneficial, obviously we're really excited to be working with you, but also if you've got your foot into those panels and those committees, to kind of be advocating for AHPs and therapists, particularly in the world of chronic pain. You know, a lot of the treatment, a lot of the support for patients is therapy focused and therapy lead, but we're just not represented at director level in the right meetings. And I think inadvertently we get forgotten about sometimes, and we rely on the medics to fight our corners a little bit. I don't know if you disagree with me, Andreas, in your experience with that, or if you think I'm talking sense. I don't know.
I'm just listening. I don't know. That sounds very valid. I probably don't see those fights enough, Natalie. That you referred to there. Yeah, thank you.
I think if I can offer a reflection back, Natalie, I think you're absolutely the way stuff gets done in trusts, the way decisions get made, does link to how hierarchical your organisation is, how the decisions get made. I'm acutely aware I'm 2 weeks in. So I'm actually drawing from the organisation. So I've worked in 4 different universities and 3 different NHS trusts, one of which was a community trust that then became 5 PCTs, I'll show my age now, and then became 1, you know. So all of those conversations really, as professions, it depends on the advocacy that you have at a high level and where your voice gets heard. So from my perspective, the fact that I directly report to the chief nurse in my NHS organisation, the fact that I'm a director at the same level as the other directors, from an NIHR point of view, the fact that we now have a national director of nursing and midwifery, Ruth Endicott, who I work very closely with, and the chief nurse, those things have made a big difference to shift the dial for funding for nurses and midwives. There's been a nursing and midwifery incubator. And I am coming to AHPs at this point. I'm just setting the scene with my experience of nursing and midwifery. So within the nursing and midwifery, 3 years ago, before the incubator, the success rate at an NIHR doctoral fellowship for nurses was running at around about 20%. Slightly better for the AHPs, but not great. And for midwives, it was around 30 to 40%. At the end of the incubator will finish in December. We've had 3 years of very concerted effort around training. And at the moment, it currently stands, nurses' success rate last year was 48%, and for midwives it went up to 83%. So it shows that actually having that high level support. The good news, therefore, is Ruth Endicott has made a case, and there will be a post going out to advert really soon, and as soon as I know, I will let you know, for the equivalent director role for AHPs in the NIHR. Because there is a recognition that very often posts like mine, it says, oh, well, you can do NMAPs, as if I can speak for all professions. And it's exactly from the medics have had to carry that load, I think, for years, which is suddenly, as medics, you're expected to speak for all professions in all places. And the reality is you're generally not even at the table. And it's that phrase, isn't it? If you're not at the table, you're usually on the menu. And you don't get to have a conversation. So it is about at a national level and cascading down from a national level, who is able to advocate for you and have advocacy. And what I tend to do is, wherever I am, if I've got a voice, then the voice tends to just go across all professions, and I try and advocate for clinical academics. And now in terms of NIHR, they'll move to clinical and practitioner academics. And the reason that the language has changed is I recognise now that the language I use is excludes my social care colleagues. So, and excludes my social worker colleagues, because clinician doesn't mean anything to them. So I start to talk about practitioner academics. And if I talk about practitioner academics, I'm broadening it out to social care colleagues as well. But so from an AHP point of view, on the horizon, there will be in the next year a call for the senior research leader programme. It runs in nursing and midwifery, has run for the last 3 years in nursing and midwifery. That's a funded post for 2 days a week at 8B to focus on getting your culture right in your organisation to enable research activity. There will be a dedicated AHP call for that April time. And the thing that I would say about that is don't be put off that the fact that it's at 8B for 2 days, because you don't have to be an 8B to apply for it. NIHR will just give your organisation 8B funding. You can be whatever grade you are, because you recognise, again, that's the other thing that sometimes gets in our way as our professions, is we get focused on grades and bands rather than what we're hoping to achieve. So so absolutely look out for the AHP, because then that will, because it has done for the last 3 or 4 years, helped that conversation and have more voices for those professions in nursing and midwifery, and has really shifted the dial on what we can do from a nursing and midwifery point of view. So I'm really hoping that the director of AHP's, associate director I think it is, and nationally will then be advocating for similar roles like mine from an AHP point of view, professorial posts like mine from an AHP point of view, because there aren't as many as from a nursing point of view, and I suspect that's just size of workforce. Don't quote me on that. I'm guessing that's been recorded, so you know, I've no evidence for that at all. It's just a guess. That answered your question, Natalie?
Yeah,
it's a bit more of a reflection.
Bit reassuring though that we've got,
so
some allies
be
out
reassured
there,
that there is an absolute desire to increase the AHP voice.
Fabulous, thank you.
And in our last 3 minutes, Michelle, if I could ask, just out of interest and starting up these relationships here between ourselves and you, is there anything that you know about from Walton Pain Services, or anything that you know we do that you would be interested in from a research perspective? Does anything jump out at you at all that you think, yeah, that's something I'd like to look into?
I don't know enough is the honest answer, which is why I'm really keen to be part of the group, because as I say, I'm 2 weeks in, which basically means, because I'm doing 2 jobs, I'm a week in. I've been like 5 days in I'm absolutely loving being part of the Pain Research Institute. I'm really looking forward to getting to know more about all of the work. I'm open to any invite, really. I'm not precious, you know, so
Lovely.
please invite me along to anything.
Actually, you've only been in post such a short time that you might not know what we do. So we'll
I've not even had a conversation with Andreas yet. I don't think we've even been in the office at the same time. I think we haven't bumped into
Probably
each other
not
yet.
No.
Yeah,
No.
the ships are passing the night.
Oh, well, hopefully not for much longer.
No,
so,
not at all.
Certainly from the Pain Management Programme Department and our research activities, we'll get in touch with you then, Michelle, if that's all right. And perhaps we could prepare some bits for you so you get an idea of what we do, you know, specifically within the Pain Management Programme Department, and a bit about our research activity. So then you've got that then, and that you can hold us in mind for any future collaborations and things like that. And I presume you'll meet with Andreas separately, or Andreas is welcome to join in the same forum, so we can sort that out afterwards. So that sounds good.
I mean, there is one thing off the top of my head that I haven't prepared, but I am aware that there is an opportunity to host research interns, get funded research interns, and early careers researchers are the people who could apply for. Have people seen the NIHR research intern bid? I will send that round with a bit of information. The closing date for that is the 18th of December, but there's funding attached to that to get, it is within your research programs to have an intern attached to that. And also, because we lobbied for it, funding for you as a supervisor as well. So there's £750 for you if you supervise an intern, and then full-time backfill for an intern. So I just think there's potentially in this group an opportunity to pull together an internship programme. So I'm happy to
Wow.
email information
sounds
around
good.
about that.
Thank you very
It'd
much.
be great to
That'll
do
be
a
wonderful.
pain research internship program. That if people would be up for doing something like that.
Mm. Yeah, that sounds good. Lovely, lovely. So that brings us bang on the minute to time. So yeah, we've covered loads, and thank you for all the extra bits of information and answering our questions at the end. That's been really, really helpful. So I'm sure, you know, on behalf of everyone else, we've all taken a lot from today and feeling inspired to engage in research as best we can. So thank you again, Michelle. And like you said, we might invite you back, you know, when you've got